Hello, my name is Kat. I'm going to be your respiratory therapist for today. We're going to do some suctioning. Is that okay? Good. All right, let me get started. Can I get your name and date of birth? Perfect. Thank you. Gonna wash my hands. Perfect. Okay. So what we're gonna do is suctioning. I want to suction through your nose and get all those secretions out. Hopefully it'll help you breathe a little bit better. Okay. All right. Gonna put a pulse ox. There you go. Got my suction kit, normal saline, and ambu, just in case. Some indications for nasotracheal suctioning are when the patient's coughing and they're unable to clear any secretions, or if they have a foreign material in their large central airway. And most evidenced by audible or visible secretions in airway. The chest x-ray will have retained secretions and atelectasis or consolidation. Also, some hypoxemia or hypercapnia could also be an indication. Suspected aspiration, tactile fremitus, and increased work of breathing to stimulate cough or for an unrelieved coughing and to obtain sputum sample. Some contraindications for nasotracheal suctioning could be absolute or relative. For absolute, the patient could have croup or inflamed epiglottis. For relative, the patient could have an acute facial swelling, head and neck injury, bronchospasm, or any type of bleeding disorder, high gastric surgery, irritability of air in the airway, laryngospasms, myocardial infarctions, nasal bleeding, occluded nasal passages, and even tracheal surgery. Let me know if it bothers you, okay? So we have to follow the natural course for the nares. Orient the catheter downward slightly, but don't force it. If we feel any resistance, we probably hit the carina. In that case, we should withdraw the catheter 1 to 2 centimeters between 0.4 and 0.8 inches before applying any suction. When we are performing nasopharyngeal suctioning, A good general rule is to insert the catheter to roughly the same depth as the distance from the mouth or tip of the nose to the angle of the mandible. In adults, that's about 16 centimeters or 6.4 inches. In older children, it's 8 to 12 centimeters or 3 to 5 inches. And in infants and young children, it's 4 to 7.5 centimeters or 1.6 to 3 inches. If we're performing nasotracheal suctioning, we should insert the catheter about 20 centimeters or 8 inches in an adult. Or older children is 16 to 20 centimeters or 6 to 8 inches. And an infant or young children, it's 8 to 14 centimeters or 3 to 5.5 inches. You're all set. So the difference between open and closed suctioning techniques. The open suctioning techniques, or the open airway suctioning, is a suctioning procedure used in a patient who will spontaneously breathe room air after being disconnected from the source of supplemental oxygen. Like in this case, for example, we remove the oxygen from the Hello Kitty. In the patient with an ET tube or a tracheostomy or an aerosol T-piece, the Briggs adapter, or on a ventilator circuit is removed, this technique is also used, but it's more preferred for a closed suctioning technique. A closed suctioning technique is a suctioning procedure used when the patient should remain connected on the original source of oxygen. This is a preferred method of suctioning any intubated patient receiving mechanical ventilation and who is likely to become hypoxic when disconnected from the oxygen source. The closed suctioning technique should be used with patients who are receiving high oxygen percentage, have positive and expiratory pressure, also known as PEEP, or at risk of lung decruitment. All right, Hello Kitty, thank you so much. Let me know if you need anything, okay? Here's your nurse's light, your call light, in case you need anything. All right, let me know.